There is a great problem on the use of steroids in non-small cell lung cancer, because we are used to use steroids for many conditions and many symptoms in this kind of patients. And the majority of the trials, I can say all the trials, excluded the patients treated up front with steroids for the registration of the drugs. So we have the effect of the drugs without steroids. But based on some results presented some years ago on the use of steroids for immune-mediated adverse events, we could see that more or less the outcomes were superimposable for patients who were treated with steroids and without steroids. So based on these results, there was always we tried to avoid steroids, but we were not so restricted in the use of steroids for the treatment of many conditions in non-small cell lung cancer. However, in this Congress, I think that one of the most relevant trials is two cohorts, one from Memorial Sloan Kettering and one from Gustave Roussy in Paris, presented results suggesting that the use of steroids given from the beginning of the use of immunotherapy increased the risk of death, the risk of progression, and they decreased the response rate. Clearly, all the people thought that this was a prognostic effect of the use of steroids, but the results also adjusted at the multivariate analysis were consistent, suggesting that you can decrease the outcomes if you use the steroids from the beginning. So now we must be very careful and try to avoid the use of steroids to leave out steroids as much as we can from the conditions in which you can, for example, replace some drugs, for example, for the pain or for some other conditions. But there is still a huge unmet need, because for several conditions, for example, the brain metastasis and the acute dyspnea, we are not able to remove steroids. So for this condition, research is needed to understand if this kind of patients need to be treated with immunotherapy or with, for example, chemotherapy or other agents.